And the National Mental Survey too, as you're well aware, nationwide community survey of mental health.
Dr. Shubhi?
Yes, sir. Sure.
Dr. Shubhi?
Yes, sir. Yes.
If all of them are there, I think Dr. Jayasuriya and Director Madam is also there. Possibly we can start off.
Yes, sir. Yes, sir. We can start.
Good afternoon. I'm Dr. Jayasuriya from the NMHS2 Central team. Today, we are having the last edition of the Mental Health Dialogues. As you know, the National Mental Survey has been on the field for the last 2 years, and we are almost in completion stage. And as a part of our outreach, academic outreach, we've been having this mental dialogues. We have had 13 editions of priority mental health disorders, and its community impact over the last 2 years. Today is the last edition. We are having a distinguished group of people, international faculty. We have a chairperson, Professor Norman Sartorius, alongside Professor Mohan Isaac, Professor Catherine M. Keys, Dr. Emil Akhtar, and Dr. Neha Dahia, who will be leading the next 1.5 hour discussion on these topics. Alongside, we have our Honorable Director, Professor Prabha Chandra, who will give our introductory remarks. We have a large group of people who have joined online for this program. I take this opportunity to welcome you all. We'll start with a short video before this program starts off officially with the introductory remarks of Professor Prabha Chandra. Can you run the video?
Thank you for every dialogue, every idea, every question, and every contribution. The mental health dialogue journey was made meaningful by the commitment, knowledge, collaboration of each members of NMHS2 family. As we conclude this final mental health dialogue, we celebrate not only the sessions we complete, but also the connection we created and the shared purpose that brought us together towards a stronger and more responsive mental health system for India. With gratitude, Team NMHS2.
Thank you, team, for that video. So, our director, Dr. Prabha S. Chandra, is internationally acclaimed for championing the cause of women's mental health. Her unwavering leadership and her support has been instrumental in driving NMHS2 to greater heights. Ma'am, we request you to kindly give the introductory remarks. Thank you.
Thank you, Prachet, and thank you, Jayasuriya. First of all, it gives me great pleasure to meet so many people online. There are around 160 people, many familiar faces, and people whom I've seen over the course of NMHS2. So it's wonderful to see that the enthusiasm continues to be there till the 14th and the last webinar. I was just looking at the dates. July 28th, 2023 was the first mental health dialogue. So it's been exactly 3 years since you started this dialogue, and the fact that we've been able to discuss and deliberate on so many matters, I think is a very important activity alongside the good work that you're doing. I just want to emphasize here that I was in the last 2 days, I have been part of the BRICS dialogue on health, which is which, as you know, is the Brazil, Russia, Indonesia, India, China, Iran, and many other, Saudi Arabia, South Africa, many other countries. 12 countries have got together in India, and India has been the chair. And one of the things that the health ministry was very keen on was to talk about mental health, and that was one of the biggest discussion points in the BRICS countries. And unanimously, all BRICS countries felt that this was the topmost thing that they wanted to discuss. But as we discussed, we realized that many of the countries actually did not have mental health surveys and were looking to India for direction on conducting national mental health surveys. So there are very few countries among the ones I mentioned. I mean, China has their mental health survey, Brazil has to some extent, but a lot of countries don't have the methodology, don't know how to do it, and they are actually looking to us to guide them, because they feel that if India can do it, with such a large country, and with so much variation in language, in culture, in social determinants, if we can do it, then the smaller countries can do it as well. And that is going to be one of the major areas of collaboration going forward. So NIMHANS was very proud because we were featured importantly in the BRICS dialogue, in the health ministers' statements. It also got the coordinating center role for centers of excellence in the BRICS countries for mental health. So I think all of this is not easy. And I think it's happening because the good work that the NMHS team has been doing, and people across the world are aware of it. So I want to congratulate the NMHS2 team and the NMHS1 team for actually, doing this survey and meeting the challenges, and hopefully teaching the rest of the world about how one can do surveys, in a manner that is very sensitive to the culture, to the language, to the nuances, and gives us very valuable data. So I just wanted to share, because this was, hot off the oven, so to say, the fact that one of the major reasons for recognition of India as a leader and as the coordinating center in the BRICS mental health arm was because of the National Mental Health Survey. So I want to acknowledge all the good work that you have been doing. And today's mental health dialogue is related to psychiatric epidemiology. We have stalwarts and experts. We have Professor Sartorius, Professor Mohan Isaac, and many others who have joined us, who are actually going to talk about, the role of psychiatric epidemiology, not just in letting us know figures of prevalence and incidence, but also trying to identify areas for resource allocation, areas where more services need to be developed, the treatment gaps, and the role of social determinants. So I think I think the psychiatric field has advanced a lot. We know that what is a risk factor for one age or one gender is probably not the same for the other. There are regional variations in all these aspects, and I think we are looking forward to listening to the experts and also then having a discussion around some of these points. I'm confident that what we discussed today will have far-reaching consequences, not just for India, but for the globe. And I'm really looking forward to listening to all of you. And as always, there are going to be discussions, and that's why it's called a dialogue, because there's lots of interaction in these sessions that we've had. So on that note, and congratulating the team for conducting these dialogues and for the last 3 years of conducting the survey and putting India on the map, on the world map for surveys in mental health, I hand it over back to Dr. Prachet. Thank you so much.
Thank you, ma'am, for those remarks. And so now let's move forward. We now request our distinguished chairperson, Professor Norman Sartorius, to give his opening remarks So Professor Norman Sartorius is somebody who needs no introduction. He is well known globally. So may I request my colleague, Dr. Latha, to kindly introduce Dr. Norman Sartorius.
Thank you, Dr. Prachit. Very good afternoon to everyone. So it's my privilege and honor to introduce Professor Norman Sartorius, a doyen in the field of psychiatry, a living legend who has shaped global psychiatry for over 6 decades. As the pioneering head of the World Health Organization International Advisory Team on epidemiology of mental disorders, and later as the director of the WHO Mental Health Division, and also the president of World Psychiatric Association, he has fundamentally revolutionized the field. Professor Sartorius spearheaded the first landmark international collaborative study on schizophrenia and depression, proving that robust psychiatric epidemiology can transform community mental health worldwide. Currently, he continues his immense global impact as the president of the Association for the Improvement of Mental Health Programs, and also as the president on the board of Geneva Prize Foundation. Even today, his commitment to education remains unwavering. He has conducted over 150 leadership and professional skills courses for early career psychiatrists across 60 nations, ensuring next generation is equipped to face evolving mental health challenges. So we are honored, sir, and I would like to request you to share your opening remarks. Thank you.
Would you like to say a few words? I was in love with psychiatric epidemiology ever since it started, because I think it is such a very important tool which we can use. But unfortunately, in the last few decades, there has been a continuous problem with using psychiatric, or for that matter, any other epidemiology in governing or in directing or in evaluating care. And the two main reasons for this weakening of the power of epidemiology, and also for the need to examine it critically so as to adjust the method to the new times, the main problems that have been arising are two. One of them has been called the deglobalization. Deglobalization is a process that has been noticed and started speaking about in the last 10 years or so. Gradually, people recognize it more and more. The deglobalization is in fact that most of the global organizations, most of the international and regional organizations are falling apart. The World Health Organization has recently suffered a significant loss of resources. But not only that the resources have not come, but because one or two of the countries have decided not to help anymore, there is a number of other places in which, in fact, the wish to work with other countries and to adjust to one's own rules and procedures, etc., with others is becoming less and less present. The recent discussions in the World Health Organization about reaction to health crises has demonstrated very clearly that the willingness and investment to do something jointly with other countries is continuously dropping. What is true for countries is unfortunately also true for within country groups. They have grown, they've become very proud of their work, justly so, but they are less and less willing to join their resources and do things together. And epidemiology is an example of a discipline which requires collaboration between those who are in the field and those who make statistics, collaboration between different disciplines, collaboration between government officials and health authorities, and so forth. So this is a big crisis before we are. There is a second contributor to the crisis, to the crisis of deglobalization. And that is the apparently wonderful tools which we have now got in the artificial intelligence and in the various advances of technology, particularly in technology that is related to numbers and to handling numbers and figures. And this has been because we have now in a situation where we are getting more and more facts easily available. But we don't need facts, we need sense. What does all this mean? And I think while the new tools on which we are now beginning to rely to the exclusion of simple tools, the artificial intelligence and regular reporting and electronic registering, etc., that produces a huge amount of data. But what does the data mean? The artificial intelligence cannot tell us, and we have stopped doing it ourselves. So that I think we will have to, as we are going on with our psychiatric epidemiology, we shall have to think of other ways to go forward. One of them should be probably that we should be satisfied with approximations rather than very detailed information, because the approximation can be obtained quickly, while a very detailed examination with a lot of data, etc., takes a lot of time, by which the world has changed already. So once we have the data, it's no longer up to date. It's not longer modern enough to be used. So one is the tendency to approximate rather than to be obsessional about the specifics or about the totality of the data that we are going to get. Second, we'll have to simplify methods, because it will be necessary to develop collaboration with other people who are working in epidemiology. And they will not have time to study this in great detail, but they can be immensely helpful if you can speak to them in a language which they understand, and if you can ask them things which are within their might. Finally, the third point which I want to say, that we shall have to think of integrating our work with other collectors of resources, of data. We should, for example, make sure that we know that the tax office in the country is working with psychiatry, because we want to know how much money is there available to families which have to look after patients. And we cannot get this only through epidemiology. We have to go into other sources of data in various places, much more than we ever did before, in order to get all the necessary information, chew it up, and find what we can suggest to governments, services, and others to do on the grounds of what I would call a new psychiatric epidemiology. In addition to this, one should also remember that many of the diseases which we have been knowing over the years have changed their form. And that, of course, is a problem that has been always with epidemiology, and I hope that we can overcome that as well. The fact that you have established one of the sessions of the dialogue on epidemiology is a wonderful experience, and I'm delighted that this is possible. So I'll be listening with much interest to all of our colleagues who will enlighten us about various aspects of epidemiology. Thank you.
Thank you so much, sir, for those insightful remarks. And we look forward to your guidance. So we now move on to our first speaker. So our first speaker is Professor Catherine Case, who would be speaking on the topic Global Trends in Psychiatric Epidemiology. So Professor Catherine Case is the Susan Lasker Brody Professor of Population Mental Health in the Department of Epidemiology at Columbia University Mailman School of Public Health, USA. Professor Catherine's research focuses on psychiatric and substance use epidemiology across the life course, including cross-generational cohort effects on substance use, mental health, and injury outcomes, including violence, homicide, suicide, and overdose. She has a focused research program on investigating methodological challenges, particularly in estimating age, period, and cohort effects, as well as using mathematical models to inform public health and policy interventions. She has authored more than 500 peer-reviewed publications and 2 textbooks published by the Oxford University Press. Her work has been funded by National Institute of Drug Abuse, National Institute of Alcohol Abuse and Alcoholism, National Institute of Mental Health, the Center for Disease Control and Prevention, and Columbia University. She is currently the president of the World Psychiatric Association Epidemiology and Public Health section. Ma'am, may I invite you to kindly deliver the talk?
Thank you so much, and thank you for the opportunity to present today and engage with this dialogue with so many others. And it's a real pleasure to present on behalf of the World Psychiatric Association Epidemiology and Public Health section. And for those early career or any scholars across the career span who are interested in becoming involved with our section, I hope you will not hesitate to contact me. We have an upcoming Congress as well as a lot of other events, and we'd love to have greater participation. So I will share my slides. Okay. And please don't hesitate to let me know at any point if there are problems seeing these slides. So I was deciding what to present today to this group, of very diverse scholars from all over. And one topic that every country that I talk to, what comes up more and more and more is the role of digital technology in youth mental health, how we're evaluating the role of digital technology, what we're doing to support youth through these controversies around whether and how digital technology is contributing to trends in global psychiatric disorders among young people. And so I'm going to share a few thoughts today that I've been developing on this topic and some of the scholarship that I've been doing as well. So I'm going to talk a little bit about the global landscape around social media and youth, and especially how elected officials are using our science. We've been developing a lot of science, and the way in which elected officials talk about that science and developing the policies related to youth mental health, I think is particularly relevant to those of us who are seeking to engage in policy-informed work, and especially how that discussion is matching the research that we're actually doing and the results that we're actually finding. And finally, policies are being enacted across the world with regard to social media, phones, and youth. How well do we know how those policies are working? So in terms of the current policy landscape around social media and youth mental health, there are kind of four areas of policy that many countries, including the United States, are currently using to try to regulate the use of social media and the use of digital technology for youth. And my colleagues and I at Columbia have really divided these policies into four quadrants. There's one area of policy intervention where governments are trying to directly regulate the youth social media experience. Then there's a second axis where governments are trying to regulate the companies themselves that are producing products that we put under the bucket of social media and digital technology. So, for example, you have a set of policies that directly regulate the youth social media experience and pose restrictions directly on social media platforms. This is things like bans of algorithmic suggestions for minors and age verification requirements. Then there's another bucket, just for example, policies that indirectly regulate the social media experience. So they're not directly tagging any policy to a social media app itself and poses restrictions on the users of those apps. So the most common thing that we're seeing across the world is banning smartphones in schools. So this poses restriction on the user. It doesn't pose any restriction on the company, and it indirectly relates to the social media experience because the kids can't have their phones at all in school. So they can't use social media, but they can't use any other things as well. And just as an example, in the United States, there are 30 states in the United States with at least pending legislation related to regulating the social media experience by minors, and 50 bills have already passed. The most common of these bills is banning smartphones in schools, but there are many, many other policies related to the social media experience that are currently being enacted or considered. Probably most people are familiar with the experience in Australia. Australia was the first country that had a set from a federal governmental perspective, a minimum age for social media accounts. So on December 10th, Australia enacted the world's first minimum age of 16 for social media accounts. And importantly, tech companies themselves and not the youth are held liable if they're deemed to have failed to take reasonable steps to prevent underage usage. Now, people are probably familiar with the experience in Australia. The early reports coming out are that many, many youth are not subject to, or they're circumventing the Social Media Minimum Age Act. And so the question that will be posed in the coming months and years is how governments are going to actually regulate the social media companies who fail to prevent underage users from accessing their platforms. But I think the broader question for us as psychiatric epidemiologists is what is the research that we're doing, and how is it contributing to the dialogue about how we should be affecting policy with regard to social media and digital technology? Governmental officials regularly cite social media as a contributor, a causal contributor to youth mental health harms. The research doesn't really match that discussion. This is the most recent umbrella review. There have been many, many, many systematic reviews, meta-analyses, systematic reviews of meta-analyses, meta-analyses of meta-analyses of the association between social media use and digital technology with youth mental health. In the most recent umbrella review, they presented harmonized effects from 102 different meta-analyses that reviewed all kinds of benefits and risks associated with youth interaction with electronic screens. These 102 meta-analyses reflect over 2,000 primary studies and almost 2 million participants who have contributed to the research in terms of what we know about social media and other digital technology and mental health. And among the many findings in this meta-analysis, I'll just point us to one, which is the association between social media use and youth depression among adolescents. The correlation coefficient for the amount of time spent on social media and the prevalence of youth depression is 0.12. Very weak association, very low correlation between the amount of time spent on social media and youth mental health. And this is very consistent across the meta-analyses. You see null to weak associations in these studies of millions of participants of the association between social media use and youth mental health. So this is fairly well accepted. In most studies, you'll see a correlation coefficient somewhere between 0.1 and 0.15. But there are some real challenges with evaluating this body of work. The first one being most studies are cross-sectional. You have a cross-sectional survey in which the researchers, us, ask youth, how much time do you spend on social media use? And then we ask them some type of standardized scale of depressive symptoms or depressive disorder. The consensus that's really emerged from this body of work is that we really haven't learned much from it. The general thing we have learned is that measures like time spent on social media or time spent on phone is just not a relevant metric for how we're evaluating the contributions of these technologies to youth mental health. So what has begun to happen is that the research has really shifted. So instead of general metrics of the amount of time you're spending with a particular product, the research has begun to focus on specific aspects of the social media use environment that are potentially harmful for youth. And I think this is particularly relevant for us as we're deciding what interventions are necessary in this work. So I'll just point out a couple of areas that my research group and many others are focusing on. One is that what has emerged is that the real risk group for harms on social media and digital technology are youth with depression and anxiety and other mental health problems. Youth in crisis turn to digital technology to either reach out for help from peers or professionals and to fuel additional symptoms. The other area that's emerged is this concept of addiction-like symptoms. Youth who report really, really heavy use and being unable to stop use. These addiction-like symptoms occur in both youth and adults. And that's where we're seeing a really strong signal of risk for both continued mental health problems as well as consequences like suicidal behavior. And then finally, we're increasingly focusing on the content of digital technology that is risky. So I'll just point out a couple of key research studies in each of those different areas. This is an example that's often highly cited, but is one of many longitudinal studies where researchers are asking whether social media use at a certain time predicts new onset of mental health problems and vice versa. And this is commonly what you'll find. So for example, here, this is social media use at time 1, predicting depression at time 2, across a longitudinal study where people were measured at multiple waves. And here you see no signal of an association. Where you see the signals of association emerge are young people who experience depression or depressive symptoms, increasing their social media use as their depression continues. And that's what you see here. There's a strong signal of depression at one time point, predicting increased social media use at further time points, especially among young girls. We did a similar study in the United States called the ABCD study, or the Adolescent Brain and Behavior Study. And I'm just going to hone in on one area of this. This is a longitudinal study where we measured social screen use, social media use where you're connecting with others, and screen use that is non-social, things like consuming YouTube videos or passively scrolling on social media. And we examined both weekday and weekend screen use. And these are the results for depressive symptoms. We classified adolescents in terms of those who had borderline symptoms and those who had clinical level symptoms of depression. And essentially what we found is that when you look at social screen time, the amount of time adolescents are interacting with others, chatting online, spending time with other adolescents, as depressive symptoms increase, social screen time actually goes down. Especially social screen time on weekdays, but also on weekends as well, is that adolescents who are depressed stop reaching out and interacting with others. What escalates during depressive episodes is non-social screen time, the amount of time adolescents are spending alone, isolated, and passively consuming content online. And again, this fuels this hypothesis that it's really not about the time that kids are spending, it's what they're doing, it's how they're using these technologies to interact with others or not. As I said before, the real signal that's emerging from the literature is around social media, quote unquote, addiction. And so it's somewhat of a controversial concept, like other kind of non-pharmacological addictions, but things like being unable to control your use, experiencing a lot of distress when you're not able to access social media platforms and other kinds of digital technology platforms. This is the most recent meta-analysis of the association between social media addiction and depressive symptoms and anxiety symptoms. And here you see a much stronger correlation of 0.27 for the association between social media addiction symptoms, kids who are actually feeling distressed by what they experience online, and depression and anxiety. And this is a study that we did in that same ABCD study in the United States, where we found that if you look at kids who have repeated and sustained high reports of social media addiction, this is where you see a strong signal with serious psychological outcomes. Here we see suicidal behavior. The prospective risk of suicidal behavior increases over 2-fold for kids who have persistent and high social media addictive use. You don't see the same associations for general measures of internalizing and externalizing symptoms. It really concentrates in high levels of suicidal behavior. We think that part of the reason why you see these associations emerge is because the algorithmic suggestions to minors and to all of us, especially people in mental health crisis, fuel the ability of young people to discover sites and chat rooms where suicidal behavior and means of suicide are being discussed. This is just one example. In the United States, there was reporting on a chat forum for individuals who are in suicidal crisis to discuss and disseminate means of fatal suicide. We examined this site in particular, as well as other what we call pro-suicide websites. And we found, if you look at the monthly searches, Google searches for these websites, it's strongly correlated with fatal youth suicide rates in the United States at the monthly level. Down here is the rate of poisoning death, suffocation death, and firearm death among young people in the United States. And I'll point your attention to these colors in red here. This is as the relative search volume for pro-suicide websites increases. This is the increase in the monthly suicide rate that you'll see, especially in the same month that the searches are occurring. We see high levels of correlation between poisoning deaths and high levels of correlation with suffocation deaths. And these are the two methods of suicide death that they're most frequently discussed on these sites. Generally, the advice on these sites is not to die by suicide by firearm because survival of a non-fatal attempt by firearm increases the risk of long-term disability. Now we're focused a lot on trying to advocate and uncover the associations with AI platforms across the world. You know, right now in the United States, at least, over 70% of adolescents are engaged with an AI chatbot. And most of what adolescents are engaged in AI chatbots for are the same things probably all of us use AI chatbots for: finding information, helping us study, and other kinds of activities. But for a smaller portion of adolescents, they're really using these chatbots in ways that are harmful. Right now in the United States, there are over 10 lawsuits against these AI chatbot companies from parents who allege that their children's fatal suicide is related to the chatbot discussions they had. This is a quote from a congressional hearing that was held in the United States with parents of children who died by fatal suicide. And one parent said, ChatGPT told my son, let's make this space the first place where someone actually sees you. ChatGPT encouraged Adam's darkest thoughts and pushed him forward. When Adam worried that we, his parents, would blame ourselves if he ended his life, ChatGPT told him that doesn't mean you owe them survival. Then the chatbot offered to write him a suicide note. So these are really chilling stories that mean that we're in a new world where we're not just, we're mandated to study the role of social media, but also these new technologies as well. So I'll just end by talking a little bit about the interventions. And this is an area where I think a lot of us in psychiatric epidemiology need to be more engaged. There are many interventions to reduce youth social media use for those that are in crisis. Shown here is the most recent meta-analysis of interventions to reduce social media use and other digital technology use across both youth and adults. There's been over 27 studies where people have been experimentally assigned to conditions where they reduce their social media use with variable designs and outcomes and follow-up times. But the point I'll make is that currently the effect is null. Of all the interventions that we've done for years to reduce social media use, it has had no effect on depression and anxiety in these experimental studies. Now research is really pointing to, smartphone bans in schools, and there's a lot of studies coming out around smartphone bans in schools. Generally, those studies report very few effects on youth mental health of banning smartphones in schools. The few associations that are emerging that I pointed out here is positive effects of banning smartphones in schools on things like bullying and overall social well-being or interactions or loneliness among students. I'll point to this study, which is the largest study that's been done on school cell phone bans in the US, and they use data from these lockable pouches where kids go to school and they have to lock their phone in a pouch for the day. So the researchers use data from those lockable pouches as well as a whole host of other data as well to examine how well nationwide for the jurisdictions that have used these devices, how well that's impacting students. And just this is over here, the year of adoption in 0, that's when you start to see these red lines. And basically there was no association with school discipline, no association with attendance, and almost no association with subjective well-being, some signal of a slight increase in subjective well-being only in the second year after school cell phones are banned, and no association with classroom attention index. So it seems like from the research that, at least for youth mental health, banning phones in schools does not seem to be strongly associated with an improvement in well-being. So just to conclude, and I'm really looking forward to discussing with everyone who's here today, really there's just much to be learned about digital technology in health. And it's a real challenge for epidemiologists because the landscape is constantly shifting. Just when we develop measures that we think are appropriate for one technology, youth shift and they're using a new technology. We are developing better science around appropriate exposure categories or this measurement challenge that we're facing and the clinical appropriateness of those categories. Where I think there is real consensus in the field is that kids with mental health problems have concentrated risk. And it's this group that we really need to be focused on supporting and intervening among. And secondly, that some online exposures, for example, these pro-suicide websites, are particularly problematic, especially for youth in crisis. And so as a community, figuring out how we can develop effective and acceptable interventions for young people and these evidence-based policies that are actually reflective of the research that we're doing are urgently needed. So I will stop there and I look forward to our discussion as today moves forward. Thank you.
Thank you very much, Dr. Catherine, for that extensive and comprehensive presentation on various meta-analysis around social media and digital technology and its impact on youth mental health. So I think you have covered extensively on including the advocacy and policy related decisions which is being shaped across various countries of late related to the social media use, and also on the importance of addiction and how some studies have even proven stronger correlation with the increase in social media use with increase in the prevalence and incidence of depression and anxiety. So I think even about you even gave some insights into AI chatbots and how they are actually guiding or misguiding youth in terms of suicide and even other incidents, which is actually very, very alarming. So I think I would like to thank you for this insightful presentation, and we will now move on with the next presentation. And I would like to invite Dr. Mohan Isaac for the next talk. And meanwhile, I request all the participants to please put on their questions in the chat box so that we can take it after the speakers. So Dr. Mohan Isaac is currently Clinical Professor of Psychiatry at the University of Western Australia Medical School, Perth, and Consultant Psychiatrist, Fremantle Hospital, Fremantle, Australia. He was formerly the Professor and Head of the oldest and largest academic Department of Psychiatry at National Institute of Mental Health and Neurosciences, Bangalore, India, where he contributed to the development of the nation's national mental health programs. And he also assisted the WHO as well as numerous international organizations, such as the Asian Development Bank on matters related to mental health. He also works with numerous non-governmental organizations across India. So I would like to welcome you, sir, and over to you.
Thank you very much. Thank you very much. I want to begin by thanking Dr. Grish, Dr. Prabha Chandra, and all the other people involved in the National Mental Health Survey too, for kindly inviting me to participate in this 14th edition of the Mental Health Dialogue, which, as was mentioned by Dr. Prabha Chandra, is the last one, as the National Mental Health Survey is soon likely to end. I also understand that you have had 13 dialogues of similar nature. The initial video indicated the various topics, etc. And it is indeed a great privilege that I'm able to participate along with the key other speakers for this evening's dialogue. I will, are you able to see my slides? I've just started sharing slides.
Yes.
Okay.
Yes, sir.
Okay. What I hope to do today in about 15 minutes is say a few words about the uses of epidemiology. Dr. Sartori has mentioned about how epidemiology's power has come down over the past 1 decade or so, but I'll just begin by how powerful it was at one time. And then I'll go on to say a few words about my own personal foray into psychiatric epidemiology in India. Then, as the organizers requested me, I would talk about certain observations about the public mental health situation in India currently. And I'll end up with making few recommendations for psychiatric epidemiology and public mental health in India. Talking about uses of epidemiology, one cannot but show the picture of Jeremy and Morris, who is very famously known as the father of chronic disease epidemiology. He was the first director of the Medical Research Council Social Medicine Unit, but he is very famously known for showing us that exercise can reduce the rate of heart diseases. And this he did by just observing the drivers and conductors of the red buses, the London buses. He found that the drivers had much higher prevalence of heart disease as against the conductors who had to run up and down the double-decker buses, and which is now, of course, well known to everybody. He wrote this paper in 1955 in the British Medical Journal about uses of epidemiology and followed it up with a book which is widely recognized as a blueprint for chronic disease epidemiology even today all over the world. And when you talk about chronic disease epidemiology, it includes psychiatric epidemiology as well. Now, he famously talked about 7 uses of epidemiology. Community diagnosis, to study the working of health services, to search for causes of health and disease, to estimate the individual chances and risks of diseases, for the historical study of health of the community, to help. This is all well known to all epidemiologists and all students of psychiatric epidemiology. But what I want to highlight is, this particular use to study the workings of the health services. This begins with the determination of needs and resources, proceeds to an analysis of services in action, and finally attempts to price. Such studies can be comparative between various populations. So his main goal was to use epidemiology to ultimately as a tool for helping to create better health for people. And my advice to the National Mental Health Survey as they are completing this second phase is to make use of all the evidence that they have generated to improve services, as I will tell you a little more about how this can be done as we go along. My own personal foray into psychiatric epidemiology began about 50 years ago when I was doing my MD training in psychiatry. And as people know, we have to do a brief thesis for your MD examination. You have to do original research. And one of the things that impressed me and inspired me very much was, of course, the chairperson who is sitting, who earlier in his remarks said that his first love was psychiatric epidemiology. He said he was in love with psychiatric epidemiology right from its very beginning. I'm quoting from one of his papers, which I had the privilege to read in the mid-1970s, 76, 77, 78, around that time, which made me reflect and think as I was planning my MD thesis. Is it necessary to do any more research in the field of mental health? There already exists enough knowledge that is not being applied. I don't know if Dr. Sartorius would remember his penning these lines in that paper. It is more than 50 years old, but it doesn't matter. It inspired me to decide on my own previous work, and I'll quickly go through some other things. I'm even now immensely proud that the very first paper I wrote with my boss, Dr. Arul Kapoor, was published in the Lancet, and without any editorial review. We sent it to the editor. He replied, if you allow to make us some editorial correction, we are happy to publish it. And within 2 weeks, it got published in 1978. This was about identifying persons with epilepsy and psychosis in the general population. That was followed up by this paper in the British Journal of Psychiatry. Anyway, the reason why I'm saying all this is the model which we proposed at the time, identify persons with epilepsy, psychosis in the community, so refer them to the primary health center. Even today, India doesn't have enough psychiatrists. So 50 years ago, the numbers of psychiatrists and mental health professionals were substantially lower. So we had to train general health doctors, etc. This was the model. This is from the paper that I referred to earlier on. And from that came the district mental health program at Bellary, which later became the prototype for the national mental health program. And also later on came the mental health policy for government of India. So if you trace the progress of public mental health in India from the after the district mental health program, around that time the national mental health program came up, and progressively the district mental health program, the Bellary model, is being implemented all over the country. It began in 1996, starting with 4 states, 4 districts, and today, according to the website of the Government of India, Ministry of Health, it is being implemented in 767, almost more than 95% of the districts in the country. Then, of course, more recently, we have the Telemanus. The other thing which has occurred is, as a consequence of the mental health program, we are in the process of reforming mental hospitals, which were called lunatic asylums. Names were changed. It became institutes of mental health, and now they are called centers of excellence. But the question I would ask at the end is, names have changed, but have things really changed as far as public mental health is concerned in India? So this is, we believe, I believe, there's a paper written along with Dr. Pratima Murthy, who is a former director of NIMHANS. We believe that mental hospitals in a transformed way will continue to have a role in India, even in the 21st century. Although, the World Health Organization, the Mental Health Gap Action Program, they all talk about closing down mental hospitals. And I believe that this is a feeling which many other people, even in developed countries, believe that there is a core group of patients who might do well with hospitals where people are looked after for a longer period of time. About the district mental health program, I mentioned that it is being implemented in 767 districts, but the reports about how they are being implemented is widely varied. In some places, of course, it has meant a difference to people with mental disorders in the district. They are able to get care closer to their homes in the primary health center, at the taluk medical centers and the primary health centers. But elsewhere, the story may be different. So much so, Alok Sareen and Sanjeev Jain wrote a paper in the Economic and Political Weekly, the 300 Ramayanas and the district mental health program. It is taking into example how there are more than 300 versions of the Indian epic Ramayana is available. The same story is told very differently by different groups of people. And so they say, who have studied the district mental health program in many places. So this is a very interesting paper about that. Now I'll go on to make my observations about the current situations as far as the public mental health is concerned in India. I'll quickly go over them and make few recommendations. Large numbers of patients are still cared for by their families, their extended families, and other care providers. This is a reality. Public mental health has improved. We have national mental health policy, but this is a reality. Similarly, another reality is the continuing role of traditional healers and alternate systems of care. Because unlike the country where I now work, there are no multidisciplinary catchment area community mental health teams. Such teams are there in most advanced and more developed and richer countries. There is absence of any social security, disability pension, insurance, like in most developing countries in India. The services are fragmented, they need integration, and there is need for substantial additional resources, both financial as well as human resources. Chronic long-stay patients continue to stay in many of the mental hospitals, which are now, of course, called centers of excellence. Human rights violations of various types continue to occur in institutional settings as well as in the community. Draconian forms of restraint, like patients being chained to some corner of the house, still occur in the country. Unscrupulous interventions by certain, not all traditional healers, I'm not generalizing the role of traditional healers, unscrupulous interventions continue to take place. The nexus between mental illness, poverty, homelessness, and wandering has been explored by various researchers in NIMANS and many other places. I'm not going into the details of the various publications. And of course, in a country such as India, as elsewhere in the developing world, and now, of course, all over the world, not just the developing world, frequent occurrence of natural and man-made disaster and with its mental health consequences continue to be a problem. In India, of course, we are yet to optimally recognize the role of persons with lived experience. They are also called experts by experience. The role of carers and user organization is still very limited. Non-governmental organizations, while the few of them which are there in India play a major role, their role is not adequately exploited. There is a need for better collaboration and integration of services, and there is tremendous scope for public, private, non-governmental organization partnerships in mental health. I'm saying this also realizing that India is already, 2030 is only another 3-4 years. India will become by then the third largest economy in the world. Population has already overtaken China's, and it will cross 1.5 billion in 2030. And by that time, about 12.5% of the population will be about 60 years of age, and more than 40% of the population will be living in urban areas. All over the country, small towns are becoming bigger cities. A city like Bangalore, as everyone who lives in Bangalore would know, has more than 15 million population, and it is rapidly growing. So just to conclude, few recommendations. Greater scope for public-private partnership, and these are all based on my recent field visits to various places in India in the past 2-3 years. Some of them I have been involved in, and one of them is the Tata Trust helped to transform the mental hospital in Nagpur. Nagpur Mental Hospital, which was one of the most archaic and old-fashioned mental hospital in India, has now become regional mental hospital in Nagpur with a lot of program, open doors, etc. And the second point I would like to make is an advice to people who are involved in the NMHS2. They are completing their study. This is a
Participants, please mute.
Yeah. So this is a paper which appeared in Lancet. I'm only showing the title.
Dr. Hitesh, can you please mute? Yeah.
Okay. So this is the title says Nations Within a Nation, Variations in Epidemiological Transition Across the States of India. This is as part of the global burden of study. They followed up various epidemiological parameters in different parts of India, and they found the title of the study is very interesting, Nations Within a Nation. This is a 15-year study. And they found that the state level disease burden variations were very marked. So this is, as you are going to analyze the NMHS2 survey, one would be very eager to know how the northeast of India is different from the northwest of India, how the south and the north are, So I'm just highlighting this point that while you have used similar methodology, etc., you would be probably commenting on nations within nations. I'm quoting the Lancet title from other diseases. They said they divided the country, that is all the states and union territories, into 4 epidemiological transition level groups. Again, I'm not going into the details. The last is, as far as the education of doctors are concerned, I understand that all postgraduates are now expected to spend more than a minimum 3 months in the rural area at a district level. This is the district residency program. But how this is being implemented is quite doubtful. In fact, many of them take long leave during the 3 months. And my brief qualitative exploration, while I believe that this is an excellent program for young doctors to get into public health as public mental health of the community, this is not being implemented properly. I would now end by making few quotes. About 2 years back, I visited the whole of Northeast India, the LGBR, the Regional Institute in Tezpur, spent a week there to know how they are implementing the district mental health program in that region. The head of the department, Dr. Kankan Pathak, at the end of it, he told me, mere allocation of fund has nothing to do with the successful implementation of any program. Essentially, what he was saying was, okay, funds are now available, but there are various kinds of bottlenecks which come in the way of implementing. Now, this is, of course, very well known. Knowing is not enough. We must apply. Willing is not enough. We must do. I would end by making 2 more quotes. People involved in public mental health last 50 years, when I was working in India, I've been involved in the district mental health program. And I like this Edmund Burke quote very much. Those who carry on great public schemes must be proof against the most fatiguing delays, the most mortifying disappointments, the most shocking insults, and worst of all, the presumptuous judgment of the ignorant upon their designs. And I will end by Stefan Probe, who wrote recently in the World Psychiatry about the political mission of psychiatry. What credibility and what societal relevance do we have as a profession if we disseminate the evidence in scientific journals, but do not care about the political action required to implement it? So to the NMHS team, I would request that, of course, you analyze, look into that, but the next phase should be the implementation to improve the public mental health of people in India. Thank you very much for a patient listen. Back to the organizers.
Thank you, sir, for that thought-provoking talk. So, yeah, we can see a few questions which we would be taking up later after all the talks conclude. So now let's move on to the next speaker. The next speaker is Dr. Aimal Akhtar. Dr. Aimal Akhtar is a psychiatric epidemiologist, a lecturer in global mental health at the Liverpool School of Tropical Medicine, and has been a consultant at WHO since 2021. His previous work includes contributing to the development of the Mental Health at Work and Mental Health Gap Action Program guidelines and a novel conversational agent psychological intervention for youth. His ongoing research includes collaborating with CZGMH on developing and preliminary field testing the FLY11, that is a flexible interview for ICD-11, aiming to prepare it for future use as a national epidemiological tool to collect country-level mental health data on disorder prevalence, health service use, and associated social determinants of health. His other research is primarily focused on the effectiveness of potentially scalable psychological interventions for adolescents and adult refugees residing in low-resource settings. So I would like to invite Dr. Aimal Akhtar to deliver his talk titled FLY11 and the Need or Scope for Structured Diagnostic Interviews in Psychiatric Epidemiology. Over to you, Professor Aimal.
Hi, everyone.
Hi, Dr. Aimal.
Girish and colleagues at the National Mental Health Survey. Can you hear me?
Yes, we can hear you.
Okay, great. So just to start, I just want to say a big thank you to Dr. Girish and colleagues at NMHS for giving me the opportunity to present at the 14th edition of the Mental Health Dialogue. It's fantastic to see that psychiatric epidemiology is being highlighted and given respectful attention. I'm also privileged to present on behalf of the wider Fly11 team, led by Dr. Jeffrey Reed at Columbia University and colleagues across all WHO regions. I'll discuss a little bit differently. I'll discuss diagnostic instruments and structured interviews and mainly focus on the newly developed Fly11. The older I get, the more I think history is very important to revisit when we're talking about new initiatives, and whether it's in research or public health implementation. So in terms of what World Health Organization's done in terms of population mental health instrument, they've been involved in the development and implementation since the early 1990s. These diagnostic interviews have subsequently been used to collect large epidemiological data, both at national levels and at global levels, to allow for the comparison and furthering of the information we know in terms of mental disorders and related social determinants of health. The most well-known of these instruments is the CDI, which was first published in 1990, and is a fully structured interview that can be implemented by both clinicians and lay interviewers to diagnose mental disorders. And the development of the tool was really propagated through extensive cross-national and cross-regional field testing and field surveys. The tool itself has continuously been updated to incorporate new editions of the Diagnostic and Statistical Manual of Mental Disorders and the International Classification of Disease, so both the DSM and the ICD. At the moment, the most recent version is able to diagnose DSM-5, but also the outdated ICD-10. It hasn't been updated for the ICD-11 at this point. The tool's been used very widely, and it's probably the most widely used structured diagnostic interview. And it was most notably used in the World Mental Health Survey, which was developed by World Health Organization in 1999. The implementation was led by Harvard Medical School in collaboration with partners at country level and across the globe. The aim of this survey was to obtain accurate cross-national information about the prevalences and correlates of mental, substance, and behavioral disorders, including the impairments, adverse social consequences, and help-seeking behavior. I think the World Mental Health Survey, it's safe to say it's probably the most important source of information on national psychiatric epidemiology for at least the past 25 years. And a lot of the findings are being used to shape policy today. However, as of a few years ago, the World Mental Health Survey is no longer a WHO study, and the CD is no longer a WHO tool. And this is, there's a few reasons for this, but the main ones to highlight is because the tool is not open access, and there's no plans for it to be made open access. And at this point, it's not been adapted to the newly released ICD-11. Other examples of WHO work on population mental health instruments include the SCAN, which is another diagnostic interview, but not applicable by lay interviewers. It has to be administered by expert clinicians and requires a considerable amount of training. But the SCAN does allow us to go beyond considering existing classification systems to look for non-classified forms of psychopathology. So, for example, a recent example is that you could use the SCAN to be able to diagnose long COVID. The connection of the SCAN to WHO has been minimal over the last few years, but the most new iteration, which is hopefully going to be released by the end of this year, is being done in close collaboration with WHO, with Dr. Terry Brugge in the United Kingdom, and will allow for assessment of ICD-11 as well. They also have, they also have non-diagnostic tools. So the HUDAS, which is very widely used, and people know it just because of how many national surveys actually incorporate this tool, is widely used to assess disability at the population level. And it's also being used in clinical trials and cohort studies to be able to look at the impact of disability. And finally, the WHO-5, which was developed at WHO. Euro is useful for outcome monitoring and mental health monitoring to assess people's subjective well-being. So there's a long history of these tools being developed at WHO, but really whose instruments are these? The CD-SCAN and WHO-5 were directly developed by WHO through WHO projects, but eventually, and because it's not necessarily part of the mandate, they gradually turned over maintenance and implementation to partners. So the control over these instruments, except for the HUDAS, which was always at WHO, ended up being substantially privatized and not under any meaningful WHO authority. And the repercussions of this was that there was a staggered usage of tools. These tools weren't necessarily realizing their full potential in terms of how widely they could be implemented and how much data could be gathered. And data collection really became fragmented with people using different tools across different regions. But what we've seen in recent years is that there's an increase in demand to understand mental health. And this was really highlighted by the COVID-19 pandemic and by the work that's being conducted through the mental health department, which is now the non-communicable disease and mental health department at WHO. One of the primary demands, especially following the release of ICD-11, was for an open access epidemiological tool to be able to conduct national mental health surveys and other population-based studies. At the same time, there was also a huge demand to assess treatment coverage because this has been largely ignored in the past, or people have been looking at help-seeking behavior, but not necessarily access to treatment. And this has given rise to the FLY11, the Flexible Interview for ICD-11, the STEPS NCD National Survey, and the integration into more clinical diagnostic tools. So now moving on from those current demands into the FLY11, more specifically, this, as I mentioned, came as a result of the ICD-11. So the ICD-11 was the first approved in 2019, and it represented the first kind of comprehensive revision of the entire ICD in almost 30 years. And this is to ensure that it incorporated major advances in research, advances in clinical practice, and information and healthcare technology over the past 3 decades. Since its release in 2019, implementation is a bit staggered across member states. But as you can see from this map, implementation is happening. And I think if there was an update to this map in 2027 based on the work that I've been doing in Europe, you'd see a very different picture with a lot of countries finally switching over fully in their information systems to the ICD-11, which is a perfect time for the FLY11 to be released as well. So this really stemmed from the need for open access instruments key to the ICD-11 specifically to support national epidemiological studies of mental disorders and other research studies. The FLY11 itself is a fully structured diagnostic interview designed for trained lay interviewers. And in terms of the outcomes, it provides a diagnostic evaluation of mental health conditions responsible for most of the global disease burden related to mental health and substance use. It's based directly on the clinical descriptions and diagnostic requirements that were published in March 2024. And the tool itself is modular and can be customized, which was something that was a request of the member states and allows for the assessment of current 12-month and lifetime diagnostic status, i.e. the most important prevalences in psychiatric epidemiology. The tool is available for adults and adolescents, and there's currently ongoing discussion on whether to develop a child version as well. Just in terms of time, I won't go through some of these slides in too much detail to make sure we have plenty of time for discussion, but these are the FLY11 modules, and the things highlighted in blue are considered the highest priority for population-based studies based on disease burden and associated DALYs and QALYs. We're also realizing as we move into more and more countries that almost every country is actually interested in collecting data on PTSD, which aligns with the whole trope of common mental disorders being anxiety, depression, and PTSD. It's important not to just collect data on diagnosis, of course. We shouldn't collect data just to collect data, especially when you take into account national surveys, the associated costs, the associated time and personnel that are required. we want to make sure to maximize this. So one of the things that's happening at Fly 11 at the moment is to identify, develop where necessary, and test additional measures and modules for population-based studies. This is with the aim of helping countries better understand the structural drivers of mental health outcomes. So whenever we do these national surveys, there's a really unique opportunity to collect information relevant to programs and policy development and resource allocation. So what we've been developing and have released already is a climate change vulnerability index, which is climate and social vulnerability, climate impact and migration history and intention. And we're also currently in the midst of developing a social cohesion / social ties / loneliness module as well to better understand that as we further understand the impact that this has on mental disorders. Again, I'll rush through this slide a little bit on the advantages and disadvantages, but the main thing is it's new. There's not been very many new structured diagnostic interviews for a long time, so it's exciting in that sense. The other big thing is that one of the advantages is that it will be open access and hopefully released by September next year. One of the things that whenever we talk to countries is about the associated costs of not just conducting data collection, but also in terms of getting access to tools. So that's been one of the main focuses, making sure that as we're developing it, we're also developing free coding, free data collection software, et cetera, for this to happen. So yeah, we need to do that. One of the big disadvantages of it being new is that we're just now collecting data on utility and validity, but there are some examples, including in India and the National Mental Health Survey, where data collection has been pushed forward because countries are able to collect data on the validation and reliability of the results. So in terms of the implementation and testing of the tool at the moment, we're currently actively conducting studies in 19 countries. And of course, this includes India and the National Mental Health Survey. And it also includes representation across all 6 WHO regions. In terms of field testing, which we're doing at the moment, is we're collecting data on the utility of it and also the interviewer experience questionnaire, which should be completed by the end of this year. This will result in an additional 10 translations, which will lead us to have more than 35 translations of Fly 11 by launch, all translations being culturally adapted and tested prior to any type of use. We're also getting information on the use of Fly 11 across a variety of settings, mainly the general population and clinical populations, both adolescents and adults, and a new work that's happening through NIMHANS is including the use of Fly 11 in primary care. And the key outcomes whenever we do field testing is understanding people's experiences receiving the interview, qualitative research to understand the test-taking experience, getting preliminary validity and reliability and other psychometric measures, and of course, being able to compare it to gold standards or more clinical interviews. I'm gonna, just because of time, I'm gonna skip this slide, but it's the next step. We really need to standardize how we're collecting psychometric data. And this is gonna be the initiative for the next couple of years for this work. In terms of other uses of the Fly 11, I think it's really important to highlight here that NIMHANS and the National Mental Health Survey has done the most work by far of anyone who's taking part in the Fly 11 initiative. And this isn't limited just to the National Mental Health Survey. This includes pre-validation work, ongoing work, testing in different settings, et cetera, et cetera. So the tool has been used in national mental health surveys where the country has had the resources available to kind of look at the adaptation and do preliminary validation work to ensure that the tool is both valid and reliable. We've just recently we're almost finished in India, where we're collecting data across all 28 states in over 18 languages with more than 250,000 people. We also just recently finalized a study in Georgia where we collected data on 3,100 adults with a focus on internally displaced persons. And we're about to start in a few months a national survey in Tunisia alongside the WHO STEPS NCD survey. We're also doing this work in other types of settings where we're looking at its use in an epidemiological study of incarcerated men and women in Germany. We've incorporated it into 2 longitudinal cohort studies. And we're looking at kind of how we can cross-culturally implement within the same borders as well. And just to kind of wrap up, I just want to talk a little bit about structured diagnostic interviews in psychiatric epidemiology. There is an importance and there is a use for these tools. I think what's really important to highlight is when we're talking about what data is actually useful for furthering mental health policy, lobbying governments for improvements in mental health infrastructure and resources, and to better understand the impacts of social and commercial determinants of mental health, we need a bit more kind of nuanced or granular data. What we're seeing more, and as we speak to more countries, we're seeing that there's an increased use of symptom scales. So of course, things like PHQ and GAD and things like this, it's becoming more common for that data or those tools to be collecting national data. There's a lot of reasons for this. Of course, it's lower cost, it's easier to use and train people. And also as of I believe it was 2019, there was a paper published by some large funders of research and talking about how now that's going to be enforced in their projects, so that they need to standardize data collection across different countries and across their different projects, and they've started this initiative. But unfortunately, the more countries we speak to, we're realizing that there's a lot of difficulty in responding to data that's actually developed through these short symptom measures. And they think that more nuanced data is required. I think for governments, there's something that doesn't work with the existing approach, and initiatives like the Fly 11, but not just limited to the Fly 11, importantly, are responding to problems highlighted by these member states. I think they're asking for more nuanced data, and to kind of unpack that a little bit, I think it's important that they want to be able to actually discuss the burden of disease, not just the burden of symptoms. And they want to have adjunct data on mental health service utilization to understand what's the mental health treatment gap, what type of adequate treatment is actually being allocated to people who require it, and to be able to come up with a story of what's happening within their borders. I think one of the things we were told is that for PHQ, for example, is if you do a national survey and then the next national survey, there's an increase in score by 2, what does that actually represent? That increases symptoms, but we don't know how to necessarily respond to that. So, and we're talking at the moment, not as part of the Fly 11 work, but as part of other work, there's discussions with some organizations in Africa about developing as mental health surveillance systems. And I think when we're talking to them, it's a very similar thing. There's aspects of having a 2-tiered system with symptom measures, but there's also a need for these diagnostic interviews and furthering the data through social determinants and things like this. And we're seeing more and more guidelines and actions plans highlight this need. We see, for example, Africa CDC just released guidelines on peacekeeper mental health, and they talked about the need for epidemiological data and diagnostic data within those guidelines. And we're seeing that's not just one isolated incident. It happens across quite a few recently released guidelines. So we need to continue lobbying for national surveys and diagnostic interviews, and not just for gathering data just to gather data, but to actually further understand the problem and better the field of psychiatric epidemiology. And we're hoping that this Fly 11 work contributes to it and contributes ultimately to our wider global knowledge on mental health. And with that, I just want to say thank you so much and looking forward to questions and discussions.
Thank you, Dr. Amal, for that very informative talk. So the fourth speaker, that is Dr. Neha Dahiya from ICMR, the Indian Council of Medical Research, who was supposed to talk on priorities of mental health research in India. Unfortunately, she couldn't join due to another commitment. So now, may I now invite our distinguished chairperson, Professor Naman Sartorius, to kindly give his reflections. Sir, over to you.
Can you please unmute?
Could you please unmute, sir?
I was saying that we have all listened with admiration to the presentations that have been made, but I think that maybe some people had some questions which they would like to ask from the speakers, and I wonder whether this is possible.
Yes, sir. In fact, there are 3 or 4 questions that I can see in the chat.
Can we invite them to speak to
Yes,
take the
sure.
floor?
So there's one question by Dr. Divya Bharti. It says, if exposure should no longer be measured simply as hours spent online, what standardized exposure metrics would one suggest so that one can adopt this for future surveillance studies? That's her question.
Yeah, and I can speak to this. Thanks so much for the question. There are, at this point, I know that there was a systematic review recently that was done of validated scales for online exposure, and these include things like, various online harms that young people and all of us report experiencing, whether that's exposure to particularly violent material, bullying, loneliness, comparisons, all of these areas that are particular exposures that people experience online already have validated measures that have been developed and are disseminated in the literature. I think there's a real need for a greater focus on developing more of those skills, and the validation that's been done has been, basic. And I think that the more we move away from things like how many hours a week do you spend online, and the more we focus as a measurement community in really developing these measurement tools, I think it's really going to benefit the field. For example, there are very few scales that discuss mental health related exposures. I know that there were other questions in this Q&A about how young people are seeking help and seeking to share information in a safe and positive way online. And there are numerous efforts all over the world to try to capture that better, but we have very, very few measurement tools in order to do that. So I guess in summary, there are many exposure measurement tools that have been developed in the literature, but that this is certainly a need for more. And the sooner we move away from these general measures of time spent, the better our measurement tools are going to get, because we're a lot of smart people who can develop a lot of really interesting tools.
Any other questions that were there that we had?
Yeah, thank you. So there's another question by Akash, which says, given the wide epidemiological diversity across various states, should mental health programs be more decentralized rather than adopting a uniform national strategy?
Professor Mohan, what do you think about that?
That is absolutely right. India is so diverse, so many different languages, so many different dialects. In fact, as the previous speaker was talking about standardization of CD, scan, etc. Bangalore was one of the centers where, one of the collaborating centers where these instruments were translated. And with great difficulty, we translated the CD and scan to Kannada, which is the Karnataka language. And then we realized that in the same state, you go about 50 kilometers from Bangalore, and then the Kannada spoken there is very different from the Kannada spoken in Bangalore. You go another 150 kilometers in Hubli, Dharwad, Kannada is completely different. So India is so diverse. As the person said, I would imagine that when the NMHS-2 survey data is analyzed, you will find these variations, and you would find that these predictions are true. Each state, and probably at the sub-state level also, there should be modifications to the program. The district mental health program is only a kind of a prototype model. It is taking mental health care closer to the homes of people, because there's overwhelming data. The farther the place of contact is, lesser would be the follow-up, higher would be the dropout. So it's only a prototype model to make mental health delivery as close to the people who suffer from them, and it is nothing else. So each state will have to develop its own model of delivering mental health care. I agree with you with the questionnaire fully, that there should be local modifications of the overall national strategy. Thank you.
I have two questions, maybe one to Professor Keys and the other one to Dr. Akhtar. Professor Keys, you have done a wonderful description of the work that has been done. My question to you is, to what extent do you think that the simple fact that people spend less time with one another and more time in the media plays a more important role than the content that is in the media?
Thank you for the question. It's such a good question, and one that we hear consistently, being discussed both among youth, among parents, and in the community. What I would say, it's a complicated question, and what I would say the tenor of the discussion has been is that there is an assumption that if youth aren't spending time online, that they are spending time interacting with others, and we know that that's not necessarily true, because there are all these different ways that youth can spend their time that's not interacting with others. And secondly, I think the relevant question for policy in terms of, for example, these social media bans is, well, if we just get the phones away from the kids, they will magically learn how to interact with each other in positive ways. And what we've seen is that that's not the case. We need these additional supports, especially for young people. I mean, if you talk to anyone who's, high school or college age right now, youth have a very hard time interacting with each other. And we don't have the intervention supports that are available to kind of scaffold these interactions to help youth develop those kind of positive connections with others. The other thing that I will point out that I think is often missing from this discussion is that there is a lot of concern, and I think rightly so, about the ways in which digital technology are affecting youth mental health. But there are kind of unintended positive consequences of preventing youth from interacting with each other. For example, we have never seen substance use lower than we have, at least in the United States and in several other countries as well, for most substances. And that's because youth are spending less unsupervised time with each other. Because I don't know about you, but when I was a teenager, and everyone I know was a teenager, where you saw experimentation with drugs is when youth are spending time alone with each other. And so, and things like teen pregnancy are down lower than they ever have before because teens are not spending time with each other. So it's not only take their phones away so they're forced to interact, but it's scaffold their development of pure social relationships in ways that are positive. And I think that that's a really a creative area for us as researchers to engage in, because this generation is different than previous generations, just like all of our generations were different than previous generations. And so kind of figuring out how to do that, I think, is an important priority.
But some countries are taking very interesting steps in this direction. For example, there is now a movement in Finland to stop giving homework to children, because the children should be with their parents during the time when they are at home or with other friends or playing football or whatever. And when they are in school, they should do schoolwork. But when they are at home, they should not do schoolwork. They should do something else. And I think that the whole question of how do we reestablish social networks and the relationship between all sorts of ages and people of different types to be a friendly group rather than a lot of individuals who are not having much connection is probably a big problem that we have to resolve.
I totally agree. And just to add on to this is that I think another question is, how do we harness technology in order to facilitate that? Because, technology is not going to go away. We're not going to take away the internet. And so, how do we use the tools that we have in more creative and positive ways, rather than just, kind of saying, get the phones away from the kids?
Thank you. Dr. Akhtar, you mentioned various instruments, and I think you described it wonderfully, what developed from the time that we started doing them. There were several instruments, however, which you didn't mention, and yet they have been used quite widely. For example, the WHO Quality of Life questionnaire is one of them. We have had about 27 questionnaires in the early 90s, and many of them have not questionnaires, but techniques of interviewing people, etc. And have these, are they still having a life of their own, or is it the diagnostic instruments mainly that have survived? the times.
No, thank you for the question. It's breaking up a little bit, so hopefully I heard the main parts of it. But in terms of just because of time limitations, of course, I focus mainly on diagnostic interviews or things that are being used in these national surveys. But of course, there's not just in mental health, but across WHO, across UN partners, there's incredible measures that are still being used quite widely in epidemiological surveys. I think the reason that the spotlight was on these diagnostic interviews is because this is really what the focus of discussions with member states have been. So I wanted to really highlight the history of diagnostic interviews specifically and tools that have been used in adjunct to them. Hopefully that responded to what you were asking.
Yeah. Well, now, of course, the development of new instruments under the conditions of great financial stringency has become much less. And the ideas of originally that there would be a constant upgrading and updating of instruments and developing new ones, etc., has gone under the off the list of priorities because there's relatively little resources that can be obtained for it. So that's probably what blocks WHO in this respect. And there are not many people who take their place with which could be taken like that. I wonder whether perhaps Professor Jayasuriya has any comments. He has vanished from the screen, but I'm sure that he is listening carefully and has enormously important questions. Professor Jayasuriya? Oops, he's gone. All right. Do we have any questions on the chat box?
Please, back. Yes, sir. Any quick comments, sir? Jayasuriya, sir?
No, Dr. Girish sir has some comments.
Yes, there was a question which you had to everybody, it says, in the chat box.
Girish, sir, anything from your end?
No, nothing yet. Nothing, no questions from my end.
Okay.
Meanwhile, while we are waiting this, Professor Mohan, you are now working in another country. And I'm interested whether, in fact, the earlier findings that outcome in India of, shall we say, schizophrenia was better than the outcome in some of highly developed countries. Do you see any traces of that in your comparison between people who had schizophrenia in India and people who had schizophrenia in Australia? Or is that gone now? You are muted.
Sir, kindly unmute.
Thank you very much, Dr. Sartorius, for that question. I spent more than 30 plus years in India working in the community mental health, etc. And more recently, not full time, but about 60% of the time in Australia. And much of the time that I do my clinical work, one as a consultant for early interventions in psychosis, which I believe is Australian psychiatrist's contribution to global psychiatry. I'm referring to Pat McGorry's work. He is the one who has pioneered what was done in Melbourne 30 years ago. You identify young people. We were talking about youth mental health. Of course, identify them with possible prodromal symptoms, etc. Help them. We can probably change the trajectory of psychosis. It may not. And of course, now what is being followed in early intervention psychosis teams are, like you do in cardiovascular medicine and cancer, etc., where you stage the disorder. In cancer, of course, no oncologist would say cancer of breast treatment of breast cancer is the same across all stages. So we stage schizophrenia or schizophrenia-like psychosis, initial first episode, first 1 year, then 2 to 5 years. If adequate things are done, I believe that even cases which are diagnosed as the Kraepelinian kind of schizophrenia, there would be a difference in trajectory, not just in India, but even here. But that is because of the early intervention and the kind of care that you provide. I think data from the Scandinavian countries in Denmark also shows that early interventions change the trajectory. In fact, in the international pilot study of schizophrenia, while Agra and Ibadan had much better prognosis, it was a Copenhagen center which prognosis-wise had the poorest in the first 2-year and 5-year follow-up, etc. Now, the other part of my time I have been spending as a consultant for the assertive community treatment team. This is a team which gets referral of most difficult cases, severe, chronic, more than 15, 20 years of continuous illness, paranoid schizophrenia, different types of schizophrenia, complex needs, lot of physical morbidity, metabolic syndrome, because many of them use various kinds of, second generation drugs. And that is when I realized, one, if these people had the benefit of an early intervention psychosis team when they first developed the problem, maybe they would not have come to the assertive community treatment team. Okay, since early intervention facilities were not there, of course, the prognosis of schizophrenia is like what we had learned from the IPSS and all that. What happens in developing countries, they run a chronic course. In spite of very good community care, the social isolation, and although they get a very good disability support pension, government provides them pension, so their motivation to do anything, and motivation even with occupational therapists and support workers and care coordinators, etc., is limited because they are reasonably well looked after financially. So some of these contribute to the continuing chronicity. As far as that is concerned, I think things are continuing to be different in India. As I mentioned even in my presentation, there is no organized disability support, disability pension, etc. They are still under the care of the families. Large number of families, a lot of mentally ill people are still taken care of by the families. And that has its own benefits because they have contacts with the families. There is no disability support. The families encourage these people to be part of, their joint agriculture work or whatever. So I think it is still India, of course. Again, as I mentioned, my presentation is rapidly changing. The joint families are breaking down into nuclear families. There are no more carers. In fact, the number of homeless mentally ill people are increasing. The number of NGOs which have come up primarily to look after homeless mentally ill people in the last 10, 15 years has been high because there are a lot more homeless people. And why are they homeless? Because families are not willing to look after. There are even stories that I do not know whether this is 100% true. I believe that it might be true. From far off states, they will give some money to a truck driver, this interstate truck drivers, and get one of their mentally ill person in the family to be taken in the truck. And, they cross states after states. From north, they come to south. When you come to south, where these kinds of facilities for homeless are much better, the truck drivers are instructed to leave them wherever they stop. So I think that India is also rapidly changing as compared to even the 25-year follow-up of the IPSS in Agra and all that. But I think some of those basic things which contributed to better prognosis still work.
Many of the developed, highly developed industrialized countries, things are now taking yet another role. There's a wonderful little poem that has been written by a person who had a life experience of schizophrenia. And this poem goes more or less like, they don't call me mad, they don't call me crazy, they don't call me bad, they don't call me. And in many ways, I think this is a model of societies now in which loneliness has gone up extremely quickly to countries, so that Japan is considering to create a ministry of loneliness to deal with people that, because they have 15% of the people who die are not discovered that they are dead for a year after they've been dead. nobody looks at them. And I think that the loneliness as such and the isolation of people and there are no more critical comments. There are no critical comments at all that people are getting. And I think that that is probably the chief problem that stands before psychiatry. How can it think of ways in which one can maintain social cohesion or social relations in some way or another, which would also help carers who are, of course, under tremendous stress, more and more so in most countries of the world. Any other questions that we have from the audience?
Some have raised hands.
Can I make
sir.
one comment?
Please,
This is not
yes.
a question. This is
Yes,
a
sir.
comment in response to Catherine's presentation. Initially, she mentioned showing the map of Australia, saying that on 10th of December, Australia was first country in the world to ban social media usage by people up to the age of 16. And we were all, of course, very proud because people were talking about how bad social media is, etc., etc. Many other countries in the world, at least a dozen countries, imitated Australia and brought in some kind of similar registration. We, of course, raised the question, is this working, not working? What I know from my clinical work, as well as working with various other people, most young people have learned how to overcome, and they are still able to do whatever they used to do before. Because either, I do not know, I'm not so well versed in various social media companies, and of course, partly supported by the companies. So while the legislation is there, it is thought of as a kind of a copyable legislation. It doesn't seem to be working. That is about social media use. But the points which we discussed earlier, whether it is useful, not useful, that of course still stays. I just wanted to respond because you raised that question. Is it working in Australia?
No, thank you so much for the comment. And just to respond to it, you know, we're conducting a lot of research in Australia right now to really understand that. And one, I think, preliminary data point that is emerging is that, yes, you know, that most people under the age of 16 who want a social media account still have a social media account. And the biggest reason that young people are citing is that the platforms never ask them to verify their age, even after the legislation. So, you know, I think there can be a healthy debate about whether these social media minimum age laws are appropriate or not. But whether they're appropriate or not, you know, there's basically at this point very little enforcement.
Thank you. You said, Lata, there was another question?
Yes, sir. There was one raised hand. Due to the paucity of time, can we end with one last question? Dr. Samina, please, can you unmute?
Yeah, good afternoon, everyone.
Yes, please go ahead.
So my question, I would say it starts from Dr. Catherine's presentation, but it's not for her per se. I would like all the speakers, I think, to give their opinions on this. So Dr. Catherine, I think her choice of the topic, that was very interesting, talking about social media use and mental health. The studies, Dr. Catherine, that you quoted, as far as I remember, the correlations that have been mentioned in the studies or in the meta-analysis, they're very low. Am I right?
Yes.
For social media and adverse mental health outcomes.
Yes. Yeah. For time spent. Yes.
Yeah. So what does that give us? What's the information that it's giving us? That social media use is having a negative impact or it's having a positive impact? We do not know that.
This is more a conversation than a question. So
yeah,
I think
that's what I'll be
yes,
getting on to the question.
Ask your questions. This will be Go ahead.
I'm moving on to the question. I'll be getting there. And if it is having a negative impact, then what is the magnitude and what is the urgency of addressing this problem? I mean, I don't mean to trivialize the matter, but what about other things that I think we should also have addressed in this mental health dialogue that I think are very pertinent right now? We have, in fact, as a part of the NMHS2, there have been qualitative studies about the same. We have done studies in prisoners, yes, homeless, and then institutionalized persons. So, and humanitarian crisis. So how should we deal with mental health in that context?
Yeah.
Because doing it in adolescents and
the
youth,
question is now
yes,
over.
Yeah, it
Sure.
can be brief.
Yeah. And I would actually want to hear from Dr. Akhtar on this in the development of the Fly 11 modules related to sort of like climate anxiety and climate change. I mean, when you talk to young people, these are real concerns that young people are having about kind of global changes. And I would be interested to hear more about what prompted the development of those modules and how they're working, kind of related to the question.
I think we are reaching the time of the end of our dialogue. So I wish to express my thanks first to the Institute, which is hosting it, and then to all the speakers who have taught us a great deal. For me, this session was particularly impactful, up to hearing Dr. Akhtar speaking of the instruments that we have started developing many years ago was wonderful, and to see again Catherine and the power of the epidemiological section and the epidemiological society, and all of this brought back memories from many places. So I want to thank you very much for your excellent presentation. I do not know, but maybe Lata can tell us, are these recordings available to people so that those who haven't listened or who want to listen again can do it? Is that possible?
Yes, sir. This was live streamed on YouTube, and it will also be available on NIMHANS YouTube channel. And those questions we were unable to answer now in the live interaction, please put it on the comments so that we can answer it on the YouTube channel also. So, and anybody who is interested, please, you can come back and watch the video which is available on the YouTube channel.
Thank you very much. So all is then left for me is to thank the speakers very much, the organizers, the Institute, and of course the people who ask questions. I hope that you will use what you have learned in your work, and that you remember the moment which we spent together in the best of senses. Thank you very much.
Thank you. Thank you very much, sir.
Thank you.
And I would now invite the co-chairpersons to take. Before that, can we all switch on the cameras for a group snap, including all the
Dr. Lata,
participants?
it may be
please?
difficult for all because we won't be able to capture individually, but we will take a snap.
Okay.
So accommodating 160 people would be next to impossible.
Well, they'll become smaller, but they still exist.
Yes, sir. Yeah. Thank you. I have the pleasant duty there is a small video, sir, which we would like to show you. Before we show that video, I would like to request Dr. Sharad to come online. Yes, Dr. Sharad is here. I would like to specifically thank Dr. Sharad Philip for bringing us, several of us together. I think Sartorius sir, I think he reached out to you, and thank you for agreeing to our request. Sharad, would you switch on your video, please? Can you spotlight him, please? Central team.
Sir, can you hear me?
Yeah. Plus, he also he took that initiative and brought in the World Psychiatry Association into this dialogue. So, yes.
Sir, can you hear me?
Yeah, I can hear. Please go
Thank
ahead.
you, sir, for the kind mention, sir. We're very happy and was to say that the World Psychiatry Association zones 15 to 17 for the early career psychiatrists, they were all keenly interested in watching here. And I'm so happy that it has been telecast on YouTube, so it is available. There were a lot of things that were discussed, and it's something that a lot of the early career researchers would now want to take forward with all the things that have been told. So we see farther because we are now on the shoulders of stalwarts like Professor Sartorius and Professor Case and Professor Isaac and Akhtar. So that's great. Thank you so much, sir, for those words. Happy to be a part, sir.
Thank you. Yeah, thank you, Sharad. Thank you, Sharad.
Yes, sir.
If I may borrow the phrase, well done job is well begun job is well done. So in that sense, I think we have had a great dialogue session. The 14th edition. I would have liked it to be the 15th edition, a whole number. But again, I think we'll always live with that bias. With a bias that we have started a dialogue, we'll continue with the dialogue. Extending this to our National Mental Health Survey. The job has been started well. I think we have had a phenomenal input from several of our partners. So this is a video putting together of all the slides, which is a tribute to all our partners. Thanks, Sharad. Yes. I would request the central team to kindly play that last slides. It's a PPS, which brings together the photographs from the different states. Can we have that?
Thank you very much. This was wonderful.
Yeah, thank you very much. I think technology also has played its role in bringing some noise to the program. But again, that's part of life. I think once again, I thank on behalf of all our team, a sincere and heartfelt thanks to the resource persons panel. Mohan Isaac, sir, you were part of the first mental health dialogue and you have been part of the last mental health dialogue. We designed it in such a way so that you would be with us. Thank you for being our mentor. Thank you for guiding us through and through. Catherine, Emil, thank you very much for making this very special to us. Norman, sir, I'm lost at words in terms of how to thank you. You've always been a person whom we look up to at NIMHANS. So thank you for all this good blessings on us. And we'll continue to dialogue. A National Mental Health Survey too is a dream for all of us. As we say, it's building an agenda for mental health care in India. We take your inputs and we would like to look at a different system for mental health care across the country. Thank you. Thank you one and all. Namaste.
Thank you very much.
3 cheers.